Consider this, a news and information program recorded on the campus of the University of Nebraska at Omaha. From the Fireside Lounge in the Milo Bales Student Center, here is your host, Carol Schrader.
Hello and welcome back to the University of Nebraska at Omaha. We have heard so much in this campaign about Iraq, the war on terror, the economy, but the other issue that really looms large in the life of so many Americans, at least 45 million in this country who are uninsured, and from a health perspective, is the issue of being uninsured or in many cases underinsured. And that can be just as serious in terms of preventive health care and staying well. My guest this week is Shelley Keel, former state senator, former congressional candidate, formerly with Together Inc. as their executive director, and now she's landed at Hope Medical Outreach Coalition as its executive director. You'll find out what that is as we go along here. You have been interested as a legislator, certainly the health care issue, the Medicaid, how we insure our children, that are poor, and all this has been an ongoing issue, and it's not getting better.
It's not getting better, it's getting worse. We are seeing a pretty significant increase every year in the country in the number of uninsured, and the state of Nebraska actually pretty much mirrors what's happening in the country with the number of Nebraskans that are uninsured. And we in the metropolitan Omaha area have about half of those folks that are uninsured right now.
In fact, we're 18th or something in the nation in terms of the increase?
Yeah.
Which is not a good, you don't want to be in the top half.
No, it would be wonderful to be 50th in the nation if we could say that, but we're not. We have really seen some significant increases in the number of uninsured and also the cost of getting insurance too.
You are with Hope Medical Outreach Coalition, and in broad terms, it's a number of really good organizations, mostly medical in nature, that work to provide services for little or no cost to the underinsured and the uninsured who are desperately in need of services. Yes. Now go on from there.
Well, Hope Medical Outreach Coalition that is underwritten by a number of health providers and hospitals and care providers in the metropolitan area, the Metro Omaha Medical Society and also the Dental Society, took on the concept of looking to try to broker medical services and dental services for those people who do not have access to insurance or have access to medical care. And we work through a number of the clinics here in the metropolitan area, primarily One World Community Health Center, which used to be the Indian Chicano Health Center
in South Omaha.
That's correct. The Council Bluffs Community Health Center and the Charles Drew Health Center. And those are where a lot of our referrals come from. What we do, we don't provide services on site. What we do is people are referred to us, and then depending upon the kind of need they have, we call our very large pool of volunteer medical providers and make arrangements for them to have appointments. We make sure that they get to their appointments, and then we make sure if there's follow-up care needed that they get that also.
Now that's a godsend. I mean, absolute godsend for some of the. What are these serious cases, or are they the kinds of things that require medical attention? There's no fooling around about that?
No, there's no fooling around about that. And the folks that get the care initially at the clinics need additional care, need additional tests. For
up
example,
the next level,
so
to speak, besides a regular clinic situation.
We had, just as an example, a family of 4 did not have insurance. Both mother and father actually were working. Mother was diagnosed with breast cancer. Okay, the clinics do not provide, obviously, a higher level of care for that kind of thing, so they called us. We arranged for all the tests. We arranged for the surgery. We made sure that the follow-up care was taken care of, and she is now okay today.
Well, thank God for that. But you can't take care of everybody.
No.
So, I mean, I've used the expression, and I don't know if it's scratching the surface, a drop in the bucket. That is what you're doing, but for each and every one of those people, it's not a drop in the bucket. It's not scratching the surface. But in terms of the people that are going without, and even with the preventive treatment that so many of us take care of, obviously flu shots is not a big issue this year because most of us aren't getting them, but those kinds of things that keep us well, keep us from being endangered physically.
Well, statistics show that those folks who are underserved, or uninsured or underinsured, there's different numbers there, are more likely to die as a result of not having health insurance. They're more likely to have bad outcomes as a result of curable diseases. They're more likely to have bad outcomes as a result of illnesses because they don't get the help that they need. They don't get the care that they need. They put it off. They can't afford to pay for the additional tests, those kinds of things. So all the way around, people who are, don't have access to care are going to have bad outcomes as a result.
Just as an example, we're having basically a skyrocketing increase in the number of increases in diabetes among all our minorities, Indian, African American, and Latino. And those are kinds of things, if you don't get early, then really severe things can happen.
Absolutely. And that's another part of actually what we do at Hope Medical Outreach Coalitions. We have a pharmacy on site, and that was just started a couple years ago. And people are referred to our pharmacy, and they come from other providers also, and they can receive their medical prescriptions at a significantly reduced cost or be enrolled in a prescription program through the pharmaceutical manufacturers so that they can receive their prescriptions at very little or if any cost at all.
And
that's
you make
tremendously
that process
important.
easier for them too.
Yes.
I mean, many people don't know it's out there, or their doctor might tell them about it, but it kind of gets
what we
lost.
do for the manufacturer pharmaceutical programs, we do the paperwork for them. So we take them through the process, get everything signed on the dotted line so that they don't have to struggle through trying to figure out how to get into a program like that. And as we know, part of the real problem with the cost of insurance, the cost of people getting sick is the tremendously high cost of prescription medicines these days.
Okay, without you being too partisan. We have a very shrill dialogue. Many people will see this show after the election is over. Some will see it before. And I don't want to get into who's better, but we have two extremes. And my biggest fear is we have this shrill, he said, she said, he's going to do this, we're going to do this is going to bankrupt this is not going to help this. And then after the election,
goes away.
It doesn't go away, but then all stuff is done behind a closed door, and all of a sudden we have a plan that, what? There won't be a national dialogue.
There's a pretty significant difference between the two major plans that are being promoted right now. Without going into great detail, the Carey plan is going to cost a lot more, but it is going to ensure a lot, or provide coverage to a lot more people than the Bush plan. Both of them, however, shift costs. The Carey plan would shift costs to a public paying kind of program. The Bush plan would shift costs to individuals. The Bush plan wants to move away from employer-sponsored plans to plans that individuals buy themselves in pools, getting together, but it would be a significant shift away from the way most insurance is paid for right now, or given out right now is through employers. The Carey plan is more or less a single payer kind of thing, whereby it's a plan across the country, and that the government would be a significant part of that. It's an interesting part of the Carey plan, however, is that it's based kind of on a reinsurance plan. If you're familiar with flood insurance, the government provides reinsurance for the most expensive, the most expensive costs associated with a disaster. Well, actually, the Carey plan investigates the idea that the government would provide reinsurance for the most expensive medical costs. So there's some interesting things on both sides.
Babies that can destroy a family with bills, or cause them to go bankrupt, and cancers, and in some of those extreme situations.
So there's a number of different things that are being considered. Tax credits, obviously, are part of that. One of the interesting parts is that they're looking at employers doing what's called a pay or play. In other words, you provide your employees with insurance, or you pay an additional and a new payroll tax that would go into a new program that would provide your employees with that insurance. So there's some different things out there.
But there's two different philosophies about how we approach that. And I imagine it's going to end up somewhere in the middle, but the issue is we're doing a pretty good job in this state of taking care of the poorest of our children through the Kids Connection, using that Medicaid money and matching Medicaid money with state money. Medicare seems to take care of the elderly, although there are lots of gaps there. Do you have
prescription drugs continues to be one of them, because unfortunately the new legislation that was passed is pretty confusing in that there are multitudes of cards, prescription cards out there, and a lot of them did not actually start right away, won't be really fully funded or fully available for several years. Those are those things that are going on with that. But we still have a real significant problem with elderly being able to get their prescription drugs.
That plan is pretty complicated. The first 2 years of it, before they work on it a little more, it's pretty complicated, even though they tried to make it easy on the internet to sign up. But each card doesn't cover the same drugs, and it's just pretty overwhelming.
And we're seeing a gap as a result. A number of pharmaceutical companies that had prescription cards for the elderly are actually ending those programs before Medicare prescription benefits are going to kick in. So there's going to be a gap there too. So we're missing pieces all over the place.
I think most people, at least in Nebraska, given the more conservative mindset, is they don't want government to do it all, because that means they're going to pay one way or the other. Maybe it'll be distributed a little differently, but the people will pay. And I mean, in essence, we all pay, because even if corporations pay, prices go up. So the issue is we're all going to pay. We have to figure how we're going to pay.
How we're going to do it. Well, and it is an important part of the discussion, which, as we've talked about, what we've heard in this election season, is that not a whole lot of talk about the actual costs that everybody is undergoing because of the uninsured population that's out there. There are serious, significant costs associated with somebody getting sick. Most people who are uninsured are actually working, and a lot of people don't realize that. Most of the uninsured are working poor. When they get sick, they're not able to support their families. When they get sick, there's lost time to the employers. They're going to end up in the system one way or the other.
The families suffer, productivity suffers, income suffers.
Absolutely. It's very, very significant cost to the community, to the state, to the country. So you pay me now or you pay me later, as they said in the oil commercial. If you don't take care of people now, you will have to take care of them one way or the other later on. And so there needs to be that part of the discussion going on, and there's not a whole lot of that going on right now.
Okay, if I were a little mouse and I was sitting not in your boardroom or what was going on, but the mindsets of some of your providers. I mean, what is kind of the buzz of how they know that their costs are going up? I mean, most of them are not for profit or
clinics,
not for profit, or they're not huge profits. I mean, Creighton Medical Center is owned primarily by Tenet, but Creighton University still owns part of it, and they don't make a ton of extra money. So they know that the costs are going up, and we do need to talk about why the costs are going up. President Bush says it's all that those malpractice lawsuits, and I think most people realize that's not the whole issue. And then, I mean, I'm not trying to, I mean, even doctors will say that's not the whole issue. So when are we going to get an honest discussion? Forget the insurance first, but the cost, where they come from, how we can fairly keep those costs in tow, because if new equipment does cost money, the new technology does cost money. I mean, we got to get down to actually what's driving that.
Well, there are a number of things that are driving it, and there's a big part of that is obviously the cost of prescription drugs. That's the largest
that
part.
taboo little thing
Yes. There are significant increases, more so than the cost of insurance overall. They're going on every year as a result of prescription drugs going up, and that is, that's a little bit of a third rail. We talk about Social Security being the third rail of political discussion. Well, that's a big, issue too. In the
corporate world, the third rail is we don't look too closely or talk about any kind of changing that system for the drug companies?
One of the things that we've got to take a look at is some of that has changed over the last couple of years, but the ability of importation, reimportation of prescription drugs is a part of that. We have to be able to do that. We have to also be able to take a look at when we want to allow prescription drugs to become generic, because once a prescription drug goes generic, then the cost goes way down, way down. And everybody who actually has insurance sees a difference in their policy as to how much the policy will pay for a name brand prescription and a generic prescription. One of the things that has been tossed around, and I actually had talked about a little bit, is taking a look at how long we allow the patent to last on prescription drugs. It's very long. It's a very long time now, and it's.
It was 7 years, but what is it?
No, it's more than that actually. It typically can run, depending upon if Congress allows the patent to continue on, can be as much as 17 years. That prescription drug can have its patent. So the idea, or the thing that pharmaceutical manufacturers will say is that well, we have to be able to make the money off of the drug.
That's
so that we can do
R&D.
I would say that actually part of the costs that pharmaceutical manufacturers are undergoing right now are the cost of advertising and public relations, but a lot of driving up the demand for the drugs, but which is they spend billions and billions of dollars on every year. I can't cite you specific studies right now. The University of Minnesota has done a number of studies on what the cost of R&D is and how long it takes a pharmaceutical manufacturer to recoup that cost, to justify keeping the patent on the drug. And one of the things that's clear is that you could shorten the amount of time a prescription drug is patented and still more than allow the company to recoup those R&D costs.
Aside from that, though, I guess I resent the fact, we talk about reimportation of drugs. I resent the fact as an American, this is not a political thing, I resent the fact that the system in Canada, which we don't want their medical system, that's but the system allows them to bargain with the drug company, so they pay less, but we pay more. And in most cases, these are our companies, but we can't bargain with them. So, I mean, the Veterans Administration bargains for their drugs, for their hospitals and medical centers. So, but that was hands-off in the Medicare.
That was a significant flaw, I think a lot of people would say, in the Medicare legislation, in that the government is a huge buyer of prescription drugs and would be a huge buyer as far as Medicare prescription drugs are concerned, and yet they were specifically prohibited from bargaining.
Now, even AARP went along with that, saying something was better than nothing.
They wanted to get something passed.
But the thing that strikes me is that we read so much about what kind of vice grip Walmart puts its suppliers under in order to be their suppliers. I mean, even so far as making Walmart to look like the bad guy. But what I mean, we hear a lot about that. That they want them to give them. We'll give you our business if you charge this little bit. And to the point where some of the suppliers aren't making that much money. Now, I don't think we want to do that to the drug companies because of the research aspect, but it kind of gripes me that Walmart can do that, but the American government can't.
Well, and it's interesting because, of course, as we just talked about, a number of the insurance plans that are being put forward, the health coverage plans that are being put forward, tout the value and the power of forming pools of buyers so that you can, get a good deal on your insurance, and yet with the Medicare legislation that was prohibited. That's something that's got to happen. You've got to be able to bargain and bring down the costs of whatever it is that you're trying to buy.
And then I think in the Medicare drug bill that we put a middleman.
We put another layer in
there, so which is great for those companies that are created. They will find business. I mean, from that capitalistic point of view. But the other capitalistic tenet that we're missing is that the power of buying, like a Walmart, should have some power.
Uninsured don't have a very large lobby, unlike some of the other, players in Washington D.C. do.
All that.
But that's a very important part of this. Is we have to give people the power to bargain, to come together, and bargain for lower prices, both in the cost of insurance overall and the cost of their prescription drugs. All of that, we need to be able to bring people together in order to do that.
But I said other countries can get a better deal. And then obviously drug companies want to make so much money. And I'm not speaking out against the drug companies, but if they, let's just assume they needed to make that profit, just for a second. Let's just assume. We shouldn't have to bear more of it than Canada.
And that's
Or some other
across the world.
Yeah,
You know, we are. You know, people like to talk about the fact that the United States pays everybody else's prescription drug bill. We do, and there are ways to do that that would not be earth-shaking. There are ways that you can leverage your power to provide prescription drug coverage for people that would not be simply going to, you know, a universal health care world or anything like that. And we just have not chosen to do it so far.
And we do need to talk about it. But let's talk about hope. And
yes.
And you know, because there's nothing going to happen soon to take care of these double-digit increases every year, at least for the last 5 years of the uninsured. So what does your organization, obviously you need people to help fund you, but I mean, what do you need to do to keep on top of trying to make a dent in this as an organization strategically?
Well, what we want to do is we can't just simply open the doors to, you know, to everybody to come in and have us just refer them off to other medical providers, because our doctors and dentists right now work very, very hard in the amount of time that they contribute towards serving people free of charge.
And there's only so many hours in the day.
There's only so many hours in the day.
And they have paid customers, and that helps.
So what we,
out.
you know, what we want to try to do is do some economies of scale, some efficiencies whereby we provide services, perhaps as revenue streams, but we provide, you know, we're looking at providing some billing services to the clinics so it's all in one place, and then that allows us to save money doing that, and then we can expand the actual medical services that we provide. We're looking to see how we can expand our pharmacy services so that even if we are not able to provide, for example, you know, free prescription or very, very low cost prescription, at least we could provide people with an alternative. We're a nonprofit, so we're not looking to make any money off of that, but to expand that so that we can provide more people with their prescriptions.
And again, you're not looking to be in competition.
No.
I mean, that's not the goal, but if it ends up a little bit that way, it's because you're on a mission, and that is to make as much of a dent in a situation that I would if I were in that situation. Well, you told me when your husband left UP, took the buyout.
And we went to look at getting health insurance for ourselves in our very, very small business that we were starting. We couldn't get insurance. We could not get insurance.
Because your husband had
high blood pressure. I'd never had a bad thing happen as a result, but they simply looked at that and said, nope, we're not going to do it. We ended up, you know, buying insurance for our kids and buying it quarter to quarter to quarter. So, you know, this is not something that one segment of the population has a problem with. This is across the board. As I said, most of the people who are uninsured are working. At least one member of the family is working.
And there's more and more people that are getting that have to insure themselves. They fell under full-time. A lot of people have fallen right under that full-time market work, or they're in business for themselves, and so they're getting very high deductibles.
Yes, or if their employer offers insurance, they can't afford the premium, or a spouse that had the insurance and they've lost their job and so they don't have insurance anymore. I mean, or they can't even qualify for the insurance that their employer might actually have, because not everybody even can get the insurance.
Depending on their pre-existing
conditions and
all
everything. So what we look to do is at Hope is find out how we can expand our services to bring, you know, to take care of more and more uninsured. As I said, almost half of the uninsured in the state of Nebraska are actually in the metropolitan area, and it's a very, very large number of people. We're serving some of them now, and what we look to do is to bring in more volunteer providers so that we can serve more people. Obviously, bringing in more funding allows us to expand services too, and I will tell you, for every dollar that we bring in, we provide $3 worth of services. So we get a big bang.
So you're parlaying that into
we get a big bang for our buck.
If we could pay a third of this, or, you know, can you squeeze this particular kind of service in, or these numbers of people?
Yeah.
So that makes them able to to jiggle their books and their calendars a little bit. I mean, just realistically speaking.
We just have to ask people to think about what it means to the community when you have folks who can't get access to medical care, and help people understand that that cost is borne by all of us.
You know, just for those that don't have too many drops of compassionate blood, and most people in this state, I think, do. If you're running a business and you are, paying some service employees, or not the high scale, and your people get sick, and they can't go to the doctor and everything, your productivity goes down.
Absolutely.
And there are a lot of employers in that situation where their employees are in that kind of situation where they're, I guess I would call them the medically vulnerable, as well as, financially vulnerable.
Well, you remember that if somebody's working, they're paying taxes. Even if, what they're making is not a whole lot of money, they're still paying taxes. And if they get sick and they're not working, they're not paying taxes anymore. So, it behooves us all to understand, the value of every working person in the community and the state, and understand that we have a better workforce, a more productive workforce. We can promote ourselves better if we're able to talk about what a great workforce, hardworking. We only miss this many days out of the work year. Those are just great ways to be able to promote ourselves to the rest of the businesses across the country. And if your workforce is healthy, then you can do that. But if you've got problems, with your workforce not being able to work because they're sick, then you can't promote yourself as well. So for strictly business standpoint, it's a good thing to make sure that people can access health care.
Well, we've been showing on the screen your website, so if people want to find out more about the Hope Medical Outreach Coalition, they can check that website. But I think one of the things that potential businesses look at when they look at locating in Omaha or expanding in Omaha is, of course, taxes and all those kinds of things. But they do look at quality of care, and I don't mean just medical, I mean the care of the community, how it cares for itself. And you're a big part of that.
Yeah, and as I have said, I hope several times in the course of this talk, we have tremendous support from medical care providers, from big to small, from the hospitals and medical centers to the individual providers to nurse practitioners, nurses, physician assistants, you name it. We get tremendous support from them, and that's a very positive thing about our community.
And they are to be commended, because if they didn't get together, and good luck with your new position with Hope.
Thank you. I'm
and
very
I hope
excited
that we
about
get
it.
some impartial discussion coming
it.
up in the next couple of years.
We all do better when we all do better.
Amen to that. Thank
and
you.
nothing heals like hope.
You've even got the pin to
Yes,
prove
that's
it.
right, I do.
Thank you so much,
Sure.
Shelley Keel, for joining us, and thank you for joining us this week on Consider This, and I hope you have insurance.
To view this edition of Consider This or past programs, visit our website at unotv.unomaha.edu. For comments or questions, call 402-554-2516 during regular business hours. Consider This is a production of UNO Television.